Hello, my name is Suzanne Trudel, and I'm a consultant at Princess Margaret Cancer Centre in Toronto, Canada, and I will be presenting our abstract from ASH 2023, which discusses pretreatment with the IL-6 inhibitor Tocilizumab prior to the CD3 bispecific Cevostamab in patients with relapsed refractory multiple myeloma. So Cevostamab is a bispecific antibody that binds to FcRH5 on myeloma cells and CD3 on T cells. This dual binding results in T cell directed killing of myeloma cells. Now, FcRH5 is expressed across the B cell lineage with the highest expression observed on myeloma cells. And importantly, it has near ubiquitous expression on myeloma cells. At ASH 2022, we presented data from the phase 1 dose-finding study demonstrating promising activity of Cevostamab in patients that are heavily pretreated. So we know that CRS is among the most commonly reported adverse events for bispecifics in general, including Cevostamab. And tocilizumab and or dexamethasone are the most commonly used agents to manage treatment emergent CRS. The aim of this arm of the G07955 study was to determine whether a single dose of tocilizumab administered prior to the first dose of Cevostamab could reduce the incidence of CRS. And this was based on preclinical data demonstrating that blockade of cytokines such as IL-6 or TNF-α could prevent CRS without negatively affecting T cell cytotoxicity. So shown here is the study design for this arm of the G07955 study. Patients were enrolled that had relapsed refractory multiple myeloma with no established therapies available, appropriate, or tolerable. So in this arm of the studies, patients received a single dose of tocilizumab, 8 milligrams per kilo, 2 hours prior to the initial dose of Cevostamab. Cevostamab was administered in a single step-up dosing schedule at 3.6 milligrams on cycle 1, day 1, and 90 milligram target dose on cycle 1, day 8, with a 90 milligrams administered IV every 3 weeks from cycle 2 onwards. Now, for comparison, we used an arm of the study where tocilizumab was not administered prior to Cevostamab, but the dose and schedule of Cevostamab was identical. That is 3.6 milligrams step-up dose on cycle 1, day 1, and a 90 milligram target dose on cycle 1, day 8. And this was used as a retrospective comparator arm. Patients in both arms were allowed to have the use of tocilizumab or corticosteroid for the treatment of emergent CRS. So shown here are the baseline patient and the disease characteristics. 31 patients were enrolled in the tocilizumab pretreatment arm and 44 on the comparator arm. Both cohorts had enrolled patients that were heavily pretreated, having received a median prior lines of therapy of 6 in the non-tocilizumab pretreatment arm and 4 in the tocilizumab pretreated group. The percentage of triple-class refractory was similar between both groups. However, there were fewer patients in the tocilizumab pretreatment group that were penta-drug refractory or had received prior BCMA-targeted therapy. So here we are looking at adverse events. On the right is a tornado plot demonstrating hematological and non-hematological adverse events by grade that occurred in 20% or more of patients. At a median follow-up of 8.5 months for the tocilizumab pretreatment group and in 12.8 months in the comparator arm, we see that the most commonly reported adverse events were neutropenia, anemia, and CRS, noting that these are commonly reported adverse events with bispecifics in multiple myeloma in general. The biggest differences you can see from the bar graphs is in the rates of CRS, which I will discuss further in the next slides, and neutropenia. The higher rate of neutropenia observed in the tocilizumab pretreatment arm was not unexpected, as neutropenia is a commonly reported adverse event of tocilizumab. However, neutropenia was reversible, manageable with growth factor support where indicated, and did not lead to Cevostamab discontinuation. So here we've discussed CRS in further detail. We can see from the bar graphs that the rates of CRS were significantly lower in the patients who received tocilizumab pretreatment at 38.7 months compared to 38.7% compared to 90.9% in the non-tocilizumab pretreatment group, reaching a statistical significance with p-value of less than 0.001. Importantly, 16 patients received tocilizumab for treatment emergent CRS in the non-tocilizumab pretreatment group compared to only 6 in the group that received tocilizumab pretreatment. Thus, overall, the rate of CRS was significantly lower in the tocilizumab pretreatment group, suggesting that tocilizumab pretreatment improves the CRS profile of Cevostamab. Now here we show the percentage of patients with, in orange, and without CRS in gray at each scheduled Cevostamab dose in cycle 1, 2, and 3. There are 3 take-home points here. First is that the incidence of CRS was primarily confined to cycle 1 in both cohorts. Second is that a single dose of tocilizumab administered prior to Cevostamab dose reduced the relative proportion of CRS at each dose of Cevostamab compared to that of the non-Cevostamab pretreatment group. And finally, that the tocilizumab pretreatment did not negatively affect the mitigation of step-up dosing on CRS. What we mean is that the incidence of CRS at the 90 milligram target dose remained lower than at the single step-up dose despite tocilizumab pretreatment. So in order to confirm the activity of tocilizumab, we looked at the peak levels of IL-6 and CRP in all patients after the 3.6 milligram Cevostamab step-up dose. We saw a rapid increase in IL-6 following Cevostamab dosing, as would be expected with CD3 bispecific treatment. The higher levels of IL-6 observed in the tocilizumab pretreatment group were not unexpected, as tocilizumab is known to inhibit the clearance of IL-6, leading to cytokine accumulation. In order to demonstrate that the activity of tocilizumab, we looked at the levels of CRP, which are normally produced in response to IL-6 signaling. And despite the higher levels of IL-6 observed in the tocilizumab pretreatment group, we see a near complete suppression of CRP in the tocilizumab pretreatment group, suggesting that IL-6 signaling is nearly completely inhibited. A similar pattern of increased IL-6 and CRP suppression was also observed with the 90 milligram target dose. So as mentioned earlier, preclinical studies have demonstrated that tocilizumab pretreatment inhibits the development of CRS without negatively affecting T-cell cytotoxicity. And consistently, we observed that the overall response rate in the tocilizumab pretreatment group was 54.8% with a VGPR rate or greater of 32.3%, compared to 37.2% of VGPR rate of or greater of 25.6% in the non-tocilizumab pretreatment group, with a similar medium duration of response in both groups. Thus, as in the preclinical data, tocilizumab pretreatment had no negative impact on the response rate of Cevostamab. So in conclusion, tocilizumab pretreatment prior to the initiation of Cevostamab therapy significantly reduces the rate of CRS in patients with relapsed refractory multiple myeloma. This effect is likely mediated through the suppression of IL-6 signaling, as we demonstrate suppression of CRP. Importantly, tocilizumab pretreatment had no negative impact on the anti-myeloma activity of Cevostamab. And although the data are preliminary and perhaps need to be confirmed in randomized studies, and prospectively, the data does suggest that tocilizumab pretreatment may serve as a way of reducing CRS CRS in response to CD3 bispecifics and reduce the burden of CRS on patients and hospitals. I would like to acknowledge the patients and families and study investigators, coordinators, and nurses that participated in the study and the sponsor, Genentech. Thank you for your attention.